Sir, before we start, all the screens have literally just gone down. So I think we need to...
Mine haven't.
All of ours have. So I'm afraid I suspect we just need 5 minutes to see if we can get them up and running again.
Well, let me fill some of those moments, because I appreciate that Professor Murphy may be keen to get away promptly at the end of this afternoon. By first of all welcoming you, and to explain, as you may know, you may have realised that there is a small but select group here in Aldwych, a much larger group outside who will be watching online and listening to what you have to say. If we take a break, which we will mid-afternoon, and there may be another short break at the end to enable those who are core participants to put further questions through their lawyers to counsel who will ask them. And during any break, you may not discuss the evidence you have given or any evidence which you think you may yet be asked to give with anyone, whoever that anyone is, but you can talk about anything else you like.
Thank you.
Are we yet ready?
No, I do have a set of questions that don't rely on documents initially.
Well,
so we could start.
I think we have a transcription up, so let's proceed. And those who may have missed it at first may have it remotely. But first of all, the first step is to invite Professor Murphy to be sworn.
Indeed.
Please state your full name.
Michael Ferber Murphy.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Yes.
And with that, the screens have come back up as well, so hopefully we won't have any more technical glitches. Professor Murphy, can we start with just a brief overview of your career? You qualified in 1974, is that right?
It was in late 1973, but my first full job was at the beginning of 1974.
And you started specialty training in haematology in 1978.
Yes, that's correct.
Becoming a consultant in haematology in St Bart's, London in 1985.
That's correct.
And then moving to Oxford in 1996.
Correct.
And your role in Oxford was initially as a consultant haematologist, but taking on a more nationally focused role in 2000 to become a lead consultant for hospital liaison for the National Blood Service.
Yes,
is that right?
That's correct. I mean, that's a very brief summary of a lot of work and a lot of time, but
absolutely.
But it's accurate.
We're going to just delve into some of that detail in a moment, just so that people understand what your broad career has been. In 2004, you became the clinical director patients at NHS-BT and remained there until 2014.
Yes, that's correct.
And then you retired fully in May 2021, but then returned 3 days a week at that point.
Yes.
And so you are still in practice, but 3 days a week.
Yes. And maybe one point of confusion, when I took on a national role, I think Lorna Williamson described it as a national director role. That shouldn't be confused as a national director role in the NHS itself, but it was a clinical director role in NHS and NBS then, now NHS-BT.
And can you just clarify what the difference is that you're drawing there?
Well, the difference is that a medical director role in the NHS itself would have some authority in determining practice in NHS hospitals. I did not have that role. I had a clinical director role in NBS, NHS-BT, where there was an expectation that I would lead a team to drive better practice, better transfusion practice in hospitals, but with no authority that an NHS medical director would have.
Thank you. I want to start at the very beginning of your career and in relation to your training period. Yes. Can you remember what you were taught about the use of blood transfusions during your medical study and early training?
Gosh, this is going back a long way. I think, do you mean during my undergraduate training?
Through until you started the specialty training in haematology.
Yes. So the answer is very little. I don't think I can remember any specific training in transfusion practice other than that I would have had during my pathology training at St. Bartholomew's.
And was there ever discussion about the risks of transfusion? Was there ever a discussion about risks of transfusion in that early training period?
I'm sure I read about risks of transfusion. I was interested in haematology as an undergraduate, and I read quite widely. I attended haematology outpatient clinics to get a greater experience in haematology. But I honestly can't remember any specific training, face-to-face training about transfusion practice.
And once you were doing specialty training in haematology, so from 1978 through to about 1985 when you became a consultant, what were you taught about use of blood transfusions?
So I was taught about good transfusion practice, both safe practice in terms of administration of blood, safe administration to avoid wrong blood transfusion. I was taught about risks of transfusion, about transfusion-transmitted infection and other adverse events to transfusion, and good use of blood. So then the indications for transfusion were rather different to what they are now, but I was also taught about good use of transfusion. And during that time of my training at St. Bartholomew's, I developed an interest in transfusion medicine, so I would have done some teaching of transfusion to medical students as well.
And what was your understanding about hepatitis and blood transfusions and the associated risks of that?
So with 1978...
1978 through to 1985.
Okay. So I'm trying to remember now when we knew about hepatitis C. That's another decade later. So I was aware that that transfusion carried risks of infection. I knew about hepatitis B transmission by blood transfusion. In the early 80s, of course, we became aware of transmission of HIV by blood transfusion, which was obviously a considerable concern. So I was aware of the risk of transmission of infection by transfusion.
Did you have any understanding of non-A, non-B hepatitis?
Well, only I don't think a lot was known about non-A, non-B hepatitis at that time, but I was certainly aware of a risk of hepatitis other than that transmitted by hepatitis B.
And in terms of AIDS, can you place at all when you became aware of the risk of AIDS through transfusion?
It was through newspaper articles. It was through the press, and then obviously through the medical press, and research coming from California and the US.
And I've also been asked to ask you what your understanding and when you came to understand the risks involved of cytomegalovirus.
The risk of cytomegalovirus and
blood transfusion.
That would have been later, probably during my time as a consultant, or maybe as a time as a senior registrar and consultant.
If we can just stay in that period before you became a consultant
Yes.
for a little bit longer.
Yes.
As a junior doctor, what did you tell patients about the risks of receiving a blood transfusion?
Yes, there would have been only few occasions, I think, in the specialties that I covered during my time as a junior doctor, where I would have been ordering blood, I would have been prescribing blood. I honestly can't remember. I would imagine I really can't remember. I don't know whether I would have given a good account of the benefits and risks of transfusion.
And
I hope I would, but I can't be sure that I would.
do you have any recollection of whether you tended to include the fact of a transfusion in a letter to a GP once someone was being discharged, or whether you were trained to do that?
So, again, this is really difficult to remember so far back.
Absolutely.
Again, I hope I would have included that. I might well not have done. It probably would have depended on the type of patient. If it was a patient that had a lot of bleeding and needed a lot of transfusion, or a patient that need very specialist type of transfusion, I might well have done, but for other patients, maybe not.
Moving forwards to your consultant work at St Bart's in London, can you just explain for us what responsibilities you held in that role?
Yes. So I had a post, a post that combined the management of patients with hemostasis and thrombotic disorders and transfusion medicine. So Bart's was not a haemophilia centre, so my role in hemostasis and thrombosis was predominantly managing patients on anticoagulant treatment, on oral anticoagulant treatment, and running anticoagulant clinics to ensure that they were getting the right doses of the anticoagulant, and providing some advice about prophylaxis to prevent thrombosis in surgical patients. But my main role was in transfusion medicine, and that included providing clinical advice to all the colleagues using blood in the hospital, but specifically the hematology medical oncology unit, which was a very large unit in London treating patients with acute leukemia and other hematological malignancies. And I spent a lot of time trying to ensure that they received appropriate transfusion, and we were taking preventive measures to avoid them having adverse effects of transfusion. And indeed, I carried out various research studies on those patients.
In terms of your interactions with other clinicians, as a haematologist, when you provided advice to them about blood transfusion practice, whose responsibility was it ultimately to decide whether or not to give a transfusion and what blood components to use?
Yeah, so it's the clinician looking after the patient who has that responsibility, and that remains so today.
And how receptive were your colleagues to the advice that you might give of whether a transfusion was needed or not?
I think it was probably very variable, and that hasn't changed either. So some are receptive, some not so receptive.
What was the process then, if there was a difference in view? If you were advising that there wasn't a need for a transfusion and a colleague wasn't particularly receptive to that, what process was then followed?
Well, the ultimate decision would be by the clinician who was looking after the patient, who was responsible for the patient. And those events are not common, but occasionally there would be questions and discussions, and usually it would be possible to resolve those in an amicable way, but occasionally there would be differences of opinion.
And if a clinician didn't seek out your advice about a particular patient, was there any scope for you then to influence practice?
Right. So
in those early days,
Yeah.
if we just focus in
Yeah.
on those early days.
yeah. So it might be that one of the members of the blood transfusion laboratory would alert me to a request for transfusion that they thought was inappropriate, and then I would have a discussion with the clinician. But most transfusions, most requests for transfusion would just be met by the blood transfusion laboratory. And in my early time as a consultant, we began to audit practice and to try and determine whether practice of an individual clinician or clinical team was appropriate or not appropriate, and to begin to collect some data to be able to talk to the clinicians about their transfusion practice and suggest some changes.
We've heard in other evidence about maximum blood ordering schedules,
Yeah.
particularly for surgery.
Yes.
Did St Bart's use those in the time that you were a consultant?
Yes.
And how were those schedules set, first of all?
Right. So this is setting the number of units that the blood transfusion laboratory would prepare in advance of surgery for different types of surgery. Some surgeries are likely to result in the need for blood very frequently, like cardiac surgery. Some other surgeries, minor surgery, would very unusually need blood. So for the surgeries needing a lot of blood, we look at the amount of blood that had been used in previous patients and work out a number of units that would cover that patient, that would be sufficient for that patient.
And how were those schedules reviewed? Were they reviewed, and if so, how?
Yes, we would review them by collecting data on the amount of blood used by the clinicians looking after those patients for a particular operation, and then have a discussion with the clinicians to say whether the number of units needed to go up or down, usually down. And then eventually, and I can't remember the exact date, we set up a hospital transfusion committee at St Bartholomew's Hospital, and that was a very good forum to be able to have those discussions with a wide range of clinicians in one go.
Just before we come to the Hospital Transfusion
Yes.
Committee, is your sense that the maximum blood ordering schedules had any impact on usage of blood?
They weren't really designed to have an impact on usage, more on the workload of the laboratory in preparing blood in advance for surgery. And if they were preparing a lot of blood and it wasn't used, then it would just get recycled. So it was a lot of work. Later on, we developed ways of minimizing the amount of blood that was prepared for surgery, and by spending a lot of time being very careful to ensure that we had the right blood group of the patient and they didn't have any antibodies against blood groups that would cause reactions or difficulty in cross-matching blood. And then, because we were so confident that it would be easy to provide blood for those patients, we could carry out a very abbreviated cross-match, or in later years even no cross-match at all, so that blood would be available very quickly. And if blood was available very quickly, then we didn't have to provide all this blood in advance of surgery. So it's more about managing the workload of the laboratory than having an effect on blood usage. I hope I've explained that clearly.
Absolutely. In terms of documentation at that time in relation to transfusion, could we look at WITN 7001-002, please? It's a copy of a leaflet we can see from the right-hand side that was helpful information for house officers. And in the middle column, we see the notes before the transfusion, 1.1, obtain consent, which is something we're going to come back to later on this afternoon. And then 2.2, keep the blood transfusion report form with the prescription chart during the transfusion. And then 5.1, attach the blood transfusion report to the notes. And if we go over the page, on the right-hand side, documentation of the transfusion in the medical notes. The following details should be documented in the medical notes for each transfusion: date of transfusion and the type and amount of blood component blood product used. Is this a document that you had or something similar when you were a house officer, first of all?
No, we developed this during my time in transfusion at St Bartholomew's. I can't remember whether it was before I was a consultant or after a consultant.
And is this the process that you expected people to follow in terms of the documentation of a transfusion?
Yes.
Can you help us with where in the notes then the number, the blood component number would be? Because if we see the documentation that's on the screen, there isn't a reference to including the specific number of the component.
Yeah. So that would be on the compatibility report form, which would go in the back of the notes with all the pathology records. The documentation of the transfusion in the medical notes is a description of what we expected the doctors to write in the clinical record of the transfusion, the clinical record of patients.
So in the I think clinical notes there would be the handwritten note, but there wouldn't be a component number.
No, the component number would be in the pathology records at the back of the notes. But the dates should match, so it should be possible to follow from the clinical notes which units were transfused on a day. So if, for example, if there was an adverse event, it should be possible to work out which unit of blood was responsible for that adverse event.
And you audited that aspect of practice, the documentation aspect of practice, in 1994. If we could turn to that, NHBT 0135088, please. And if we pick up on the second column, it describes the work that was done. The questions were designed to audit ward practice both on the day of transfusion and 1 day post-transfusion. The audit was divided into 4 sections. 46 transfusions of red cell concentrates were given over a 2-day period. Audit information was collected by 2 medical students. The first section related to the location of the compatibility report, which has essential information about the patient and the units to be transfused. It should be readily available during and after the transfusion. It should be in the patient's prescription chart during the transfusion and be fixed in the patient's notes afterwards as a permanent record of the transfusion. It was found that during the transfusion, the report was in the prescription chart in 28 of the 46 transfusions, 61%. In the other cases, the report was on the patient's locker, in the blood bank refrigerator with the untransfused units, in the ward equipment room, and it was not found at all in 3 cases. On the day after the transfusion, the report was found in the notes in only 30% of cases. Others were found in the prescription chart, at the bedside or on the nurse's desk, but 7 were not found at all. Performance varied according to the ward. For example, in the intensive care unit and in operating theatres, the reports were found in a variety of places during the transfusion, and filing the reports in the patient notes was particularly poor on the oncology wards. And then if we go over the page, it deals with the 4th section of the audit. The 4th section examined the documentation of transfusion in the patient's notes. There was some documentation of the blood transfusion in 72% of the medical notes. This was usually a brief note, such as transfuse 4 units of blood tomorrow. And then towards the bottom of this column, the results of these audits were publicised in the hospital newsletter and at a general audit meeting for medical staff, following which the chief executive wrote to all medical staff, emphasising the importance of complying with existing procedures for blood transfusion and encouraging better documentation of transfusions in the medical notes to include the clinical indication for the transfusion, the type and amount of the blood component blood product used, the effectiveness of the transfusion, and the occurrence of any transfusion reactions and their management. Now, Professor Mercier, this audit was conducted in 1994. Was it your sense that that represented the practice in the hospital over a number of years? Or had something particularly happened in 1994 that made documentation more challenging?
No, we thought that it represented practice at around that time. And I must say that actually, if I was to carry out a similar audit even now, the practice might not be found to be much better.
And looking backwards from 1994 further into history, into the 1980s and 1990s, did this audit in 1994 surprise you, or did it seem coherent with what you'd experienced in the 1980s and early 90s?
I mean, it's hard to answer that, but it didn't surprise me, and I suspect that the practice was similar earlier than that. It is very difficult to think about how transfusion is delivered in hospitals. It's delivered by most of the nurses and doctors. So any trained nurse, any trained doctor can have an involvement in transfusion practice in a hospital. In Oxford, we have 4,000 nurses, nearly 2,000 doctors, so any of them could have an involvement in one of the stages of transfusion. So to deliver training effectively and to ensure that their practice is as good as it could be for every aspect of transfusion is incredibly challenging.
And in Oxford, you've put in some electronic solutions, which I'm going to come to later
Sure.
this afternoon, if I may.
Is it the case that throughout the 1980s there was an increasing awareness of the desirability of being able to trace the donor and the recipient of a particular unit?
Yes, and I think that is correct, because of the issues raised by transfusion-transmitted infection.
So intuitively, one would expect that emphasis to result in those individuals administering transfusions to take rather more care than they had previously done. You
might hope so, but whether that would actually happen or not is obviously difficult to say.
I'm asking because if one has a focus on the 1980s, as Council has just asked you to have, and your only clue is an audit in 1994, the chances ought to be that the audit is actually revealing a slightly better picture, even with figures such as the ones you've quoted, than would have been the case if it had been conducted 6 or 8 or 10 years earlier.
I think it's just very difficult to know without having the data. I mean, the data are not impressive in 1994.
No.
In a hospital where, you know, we were doing our best with, you know, with some resource for educating doctors and nurses in transfusion to do the right thing. So it might well be that practice was even worse earlier than that.
And following on from your last comment, the chances might be, although we don't know for sure, that they might be worse in those hospitals which didn't have the ability or the resources or the inclination to have extensive training of their staff.
It's certainly possible.
Yes, thank you.
From that audit that you undertook, the hospital then produced revised guidelines in relation to blood transfusion. Could we look at those? WITN 7001-003, please. It's revised in 1996. And if we turn the page to page 3, are these, sorry, first of all, are these the revised guidelines that followed?
Yes. Yes, so I recognise the document, and obviously I provided it to the inquiry.
Indeed.
Yes.
And then if we turn to page 3, we see introduction. A blood transfusion is a potentially hazardous procedure which should only be given when the benefit to the patient outweighs the risks, the most important of these being hemolytic reactions and transfusion-transmitted infections. And then under procedure, before the transfusion, obtaining consent, the reason for needing a transfusion and the risks involved, e.g. transmission of HIV, less than 1 in a million, hepatitis B, less than 1 in 20,000, hepatitis C, less than 1 in 13,000, should be explained to the patient. It's not necessary to obtain written consent for blood transfusion. Verbal consent is sufficient. Where consent is not possible, e.g. in emergency situations, clinical judgment must be used. If a patient or guardian refuses to consent to a transfusion, the matter should be referred to a senior doctor for advice. I'm going to come back to consent later on. I just want to flag that it's there in these guidelines in 1996.
Yeah.
And then we turn to page 5, please. We have the heading Identification Procedure before the transfusion, and at D, we see the requirement to write the unit number on the blood transfusion prescription chart, and then 2.2.2, location of compatibility report, keep the blood transfusion report form with the prescription chart until the transfusion is completed, when it must be fixed in the pathology report section of the patient's medical notes. And then page 7, please. 2.6, completing the transfusion. Attach the blood transfusion report form to the pathology report section of the patient's notes. Seal the blood bags using the spigot attached and dispose of the bag. First of all, what changes in practice did these guidelines require?
I think they were written to reflect what we hoped practice was and to encourage greater compliance with good practice.
So who did these guidelines go to?
I can't remember exactly how they were distributed, but the aim would have been to distribute them to all the clinical teams in the trust, and by this time St Bartholomew's was merging with the Royal London, I think. So we would have been distributing them in various ways to the clinical teams throughout the trust, including via the Hospital Transfusion Committee, which would have representatives from all the major clinical teams using blood in the trust.
And so is it right that if it went to the Hospital Transfusion Committee and others, and then it
Yes.
would be cascaded
Yes.
out down to clinicians?
Yes.
And in terms of the Hospital Transfusion Committee, do you have any recollection of when it was established at St Bart's?
Without going back to my statement, I think it was probably at the end of the 1980s. I can't.
I can double check it and confirm it after the break.
Yeah.
Can you help us with, at the St Bart's Hospital Transfusion Committee, which specialties were represented at the committee?
So critical care, haematology, medical oncology, surgery, obstetrics. Those are the major ones. Emergency medicine. Those would be the major ones that were represented.
And what was attendance like at the committee? Did people tend to attend the meetings, or was there a difficulty in getting clinicians to be there?
Yeah, I think when we established the Hospital Transfusion Committee, we had quite good attendance. It was new. We had good support from the hospital managers, and we decided that we would have a chair as a non-haematologist to try and indicate to other clinicians that this was not just haematology trying to bash clinicians over the head about blood transfusion practice. And that worked quite well, I think, initially. But it's asking quite a lot for clinicians to come to specialist committee meetings. And over the years, both at Bart's and in Oxford, it has been difficult to keep interest and attendance up at the Hospital Transfusion Committee meetings. And it's not just at Bart's and Oxford. This is a worldwide issue of trying to engage clinicians, non-haematologists, and even clinical haematologists who are mainly treating patients with malignant haematological conditions who use a lot of blood, to keep them interested, to maintain their interest in transfusion practice and their attendance at Hospital Transfusion Committee meetings.
And what interactions were there between you and St Bart's and the regional blood centre?
So the regional blood centre for Bart's was at Brentwood. So they provided us with blood. So we would order blood from the regional blood centre. So a regular supply would come according to our order. We would order some specialist products. They would carry out some reference services for us. They would be available for medical advice, for clinical advice when we wanted it. We had a very good relationship with the regional blood centre at Brentwood.
And what advice and recommendations did you receive from them about appropriate use of transfusion?
Yeah, so I'm not sure that they saw it as their role to give us advice about appropriate use of blood. The recommendations that we used about appropriate use of blood would come from other directions. They come from the British Committee for Standards in Haematology, who produce guidelines for various aspects of haematology, including transfusion, and from what evidence we could glean from clinical trials and the literature in later years when randomized clinical trials became quite commonplace for use of blood.
Thinking about those guidelines from the British Society of Haematology, the British committee, how were the haematologists involved at all in cascading those guidelines to other clinicians, the non-haematologists?
I'm not quite sure who you mean by the haematologist.
So yesterday we heard evidence from an obstetrician and an obstetric anaesthetist, and we talked with them about some guidelines that have been produced by the British Society of Haematology, and they weren't familiar with those guidelines. Was that something that at St Bart's there was a method of getting guidelines to non-haematologists?
Yeah. So it's very challenging to do this, but we would certainly try to do this through the Hospital Transfusion Committee and other ways where we thought there was a particularly important guideline to make sure that it came to the attention of the specific clinical team, if say it was an obstetric team or an emergency medicine team. But I would imagine that challenge was met in different ways in different hospitals.
But in St Bart's, it was primarily, I think you're saying, through the Hospital Transfusion Committee or from action by the haematologist?
Yes. And that would have been me. You know, when I was responsible for transfusion medicine, that would have been me.
Before we leave St Bart's, you've said in your statement that during the 1980s and the 1990s, a patient would generally receive red cell transfusions if their haemoglobin was less than 10.
Yeah.
And that in your view, practice only really changed following a particular journal paper, the TRIC trial, in 1999, which we won't go to, but it relates to intensive care patients that showed that lower levels of haemoglobin wasn't harmful. Do you have any sense as to why it took until 1999 for that appreciation to be reached?
Well, we didn't have the evidence for anything different. So we had nothing to go to other clinical teams and say, you know, this is what you should be doing. We would encourage them not to give top-up transfusions at a hemoglobin over 10 because we felt that was inappropriate, even though we didn't really have the evidence to say so. But that was the accepted level of for good practice for transfusion. So it really was a landmark trial, the TRIC trial in the late 1990s, that drew our attention to the fact that lower hemoglobin levels could be used to decide whether patients would be safely transfused.
You moved to Oxford in 1996. Can you tell us briefly what responsibilities that role involved? Yes.
So I came to Oxford at a rather strange time. There were major changes in the blood service in England at that time, and the Oxford Transfusion Centre, it was decided, was going to close down, and that wasn't greeted with much enthusiasm in Oxford, because my eventual clinical colleagues were concerned that they would find it difficult to get the blood that they needed. Eventually, what happened with the Oxford Blood Centre was that the supply of blood came from Bristol, but some reference services were held in Oxford. But the centre itself needed a new raison d'etre, and part of the reason for my appointment there was to provide that raison d'etre by providing a clinician who could work closely with other clinicians in the hospital to provide advice about transfusion practice, which they had not had before, and also to work with other colleagues in the blood service to develop guidelines and try and drive better transfusion practice in the whole of that area of the blood service, which was the Midlands and South West zone at that time. So I worked with colleagues in the other blood centres in Bristol, Birmingham and Southampton to try and roll out good transfusion practice to the hospitals in that zone.
And in terms of the nature of that role, is it right that your role was, in a sense, limited to seeking to influence others? You didn't have any powers to require people to change. It was very much a leadership role in that sense.
Yeah, and that's what I've always had. I've as I tried to explain earlier on, I've never had authority to tell people to do anything. It's been my effort has been to influence others to try and deliver good transfusion practice.
Key, from your statement, key to a lot of your work has been the Better Blood Transfusion Initiative. And so I just want to deal with what that covered over a period of time and then address some of the specific aspects of the initiative itself. Could we turn up at NHBT 00837001_002? It's the first health service circular, which the inquiry's seen a number of times over the last few days. It's dated the 11th of December 1998. And if we turn to page 2, we see the heading Action, and it addresses the need to ensure that hospital transfusion committees are in place and that trusts participate in the annual SHOT inquiry, and that thereafter trusts have agreed and disseminated local protocols for blood transfusion and explored autologous blood transfusion and perioperative cell salvage. Why were these actions particularly identified as, at that time, as key to progress?
Maybe if you go further back to the document, it gives some of the background to the Better Blood Transfusion.
I think if we just go up to the second paragraph, is that what you're...
Yes, that's right. So these were the concerns about blood transfusion in advance of this Better Blood Transfusion initiative. So there was concern about increased use of blood. There was concern about the adverse events to transfusion that the SHOT initiative, which was established in 1996, was turning up. And there was concern about the transmission of variant CJD. So these were the issues that were really driving this initiative to really develop much better transfusion practice in hospitals.
What, in terms of the action points that then followed, why could they not have been introduced in, say, the 1980s?
They could have been introduced, but the imperative to do so, the evidence that they were really needed wasn't there. So it was only with a survey of adverse events to transfusion that was carried out before SHOT was established that indicated the scale of wrong blood events. So this was a survey carried out by Brian McClelland, a colleague at the Scottish National Blood Service, and he asked hospitals to tell him about the number of ABO incompatible red cell transfusions that had occurred in their hospital during I think an 18-month period before that. And the number was very concerning and led to as I said, to the establishment of SHOT. But it was the first time that the scale of the problem of wrong blood events was really documented well.
Do you have any insight into why the scale of the issue hadn't been appreciated after the AIDS crisis and the discovery of hepatitis C and the impact of that on people who've been transfused? Because this is dated 1998.
Sure.
It's quite late. Why, when it was ABO incompatibility, but not the transfusion-transmitted infections?
I think that's a good question, and I can't give you an answer to that. So they're both really, really important in terms of good transfusion practice. So why the problems identified with transfusion-transmitted infection didn't drive this sort of initiative, I don't know. But I think it was that all I can say that it was the combination of concern about variant CJD, wrong transfusions, increased demand for blood that eventually led to this Better Blood Transfusion Initiative, which was a really important driver to better transfusion practice, and it continued, as you know, through a number of iterations.
And we're going to look
Yes,
at that.
okay.
If we could turn to page 3 of this document, paragraph 10, we pick up the minimum requirements for a hospital transfusion committee. The inquiry again has looked at these before. Is it right that these, as it says, were the minimum requirements for a hospital transfusion committee?
Yes, so those bullet points cover the main actions of main activities of a hospital transfusion committee.
And again, what barriers, if any, were there to an earlier introduction of hospital transfusion committees across the country?
So this was 1998. I think we established our hospital transfusion committee at Barts in the mid-late 80s. And we did so probably because we had an interest in transfusion. The lead of the haematology department at Barts was interested in transfusion medicine, as I was. So we had an interest and some resource to drive better transfusion practice, and we became aware of hospital transfusion committees, I think, from the United States. And probably we were one of the first hospitals to introduce a hospital transfusion committee at Barts. I know there were others. Professor Contreras at the North London Blood Centre also was a proponent of hospital transfusion committees in her region.
We heard this morning from Dr. Wallace about the transfusion committee in the Freeman, which was also fairly early doors.
Yeah.
But why do you think it wasn't introduced on a national level earlier than 1998? Do you have any insight into why that was?
I suspect it was because in many hospitals there wasn't the leadership to do so. I'm trying to remember when. I think the British Committee for Standards in Haematology produced a guideline statement. It may not have been a guideline, but certainly a position statement about hospital transfusion committees. I can't remember when that was published. That was written by Professor Alan Waters, who I work with at Barts, probably about the time that we developed our hospital transfusion committee at Barts.
So I'd need to look that date up, but I can certainly do so.
Yeah.
I'm hoping that perhaps someone behind me will look that up. If we move forwards to the second circular, AHCH 5055. Thank you. We can see the dates, the 4th of July 2002. And if we can go forwards to page 6, please. And we see here that a survey of progress that had been made in blood transfusion practice since the first conference in 1998 was presented at the conference in 2001. It highlighted that in some areas of blood transfusion practice there was very good progress, the establishment of hospital transfusion committees and participation in the SHOT scheme. But then, if we just go down, in other areas more needed to be done: multidisciplinary staff training in the process of blood transfusion, availability of hospital transfusion practitioners, local approved protocols based on national guidelines for the appropriate use of blood, and then the final, audit of blood transfusion practice, and then the final bullet point, the provision of written information to patients on blood transfusion. Again, do you have any insight into what the reasons were for the limited progress in relation to those areas that are highlighted here?
So this is a bit of a running theme over the next years and probably going back a bit further. So it's lack of leadership, for transfusion in hospitals, and it's lack of resource to really prioritise transfusion practice as something that was really important for hospitals to do.
Because, as you say, as one reads the subsequent circulars, the subsequent surveys, many of the same issues keep coming up as things that haven't been achieved.
Yes.
Would that be fair?
It is fair, and it's still fair now, unfortunately, that the leadership for transfusion in hospitals and the resource for delivering really good transfusion practice in hospitals is lacking. That's not to say that we haven't made significant progress in transfusion. That's well documented by SHOT that the number of serious wrong blood events is reduced a lot. The inappropriate use of blood is much less than it was. But we still have some serious wrong blood events. They're now called never events. And we know from our audits that there is still a fair amount, I'm talking 20% or so, of inappropriate use of blood. And we've just carried out an audit of the NICE quality standards for transfusion.
Which we will come to.
Fine, okay.
Absolutely. We are going to bring it right up to the
Yes.
present day,
Yes.
because that audit was only published about a week ago.
That's
so
right.
we will get there.
Yeah.
I just want to take it in chronological order, if I may. And the next thing I'd like to take you to is DHSC 304205_005. I should say again, sir, I'm going to take you through the chronology of the Chief Medical Officer's better blood transfusion and then come back to specific issues to delve into them in a little bit more detail. These appear to be notes to prepare for a meeting with you, for a meeting on the 2nd of May 2006. And we can see that it indicates that issues that were likely to be raised at that point was progress to date of the better blood transfusion, refocusing and re-energising BBT, the need for further research into the use of suitable alternatives, MPSA DH initiatives to improve safety at the bedside, the use of information technology, including the Do Once and Share initiative. And then there is a set of headline information. I'm just going to read some of it and then I'll ask you about it, Professor Murphy. Since the second CMO seminar 3 years ago and the publication of the more detailed Health Services Circular HSC 2002/009, there has been a fall in the demand for red cells of 11%. As a result of efforts to use blood more appropriately, red cell demand fell by 5.7% in 2004 and by another 4.7% in the first 10 months of 2005-2006. And then it indicates the savings. Success is attributed to the establishment of hospital transfusion teams with dedicated consultant and transfusion nurse practitioners in each trust. The degree of success is proportional to number of people in this team and the length of contract. The appointment of MBSBT the appointment by NBSBT of regional nurses to support the trusts, the work of the blood stocks management scheme, and the contingency plans for shortages of blood and platelets. This 11% fall is actually quite modest. A stakeholders workshop found excellent practice spread over a number of trusts, but a variable penetration of all good practices in these trusts, with no trust implementing all areas of good practice, few implementing elements of all these three initiatives. Raising awareness, education and audit, alternatives to transfusion, changes to laboratory practice, and indeed very few implementing Initiative 4, preparing patients for surgery, despite a report claiming this could save 240,000 units of red cells. This has actually caused a net fall in costs to the NHS, but in the current financial situation, there is a concern that some of the key people that might be seen as not frontline staff, and in some cases posts, have been made redundant. Just pausing there, obviously these were notes ready for a meeting with you, but does that synopsis reflect your understanding of the position in 2006 as well?
Yes, it does. I remember this meeting very well. It was a meeting with Professor Sir Liam Donaldson in advance of the third iteration of Better Blood Transfusion. And he was a tremendous supporter of the work that we were doing in Better Blood Transfusion. I was pleased to receive this note with the papers recently, and the note that I received had his notes annotated to this document, which were really interesting and demonstrated his involvement and keen interest in what we were doing.
Well, Professor Murphy, you've just solved one of the problems that our team had, which was the another, as you say, another referenced URN for this has some notes, and we weren't sure whose notes they were. So clearly they were Professor Donaldson. You recognise his handwriting.
Yes, yeah.
If we continue reading, this note indicates all of the initiatives to date have focused on surgery, because that's an area where there's been some audit and evidence-based research. However, because not all hospitals use all possible methods to reduce transfusions, there is still much work to be done here, as confirmed by a recent detailed audit in Northern Ireland, which has estimated that 20% of red cell transfusions remain inappropriate, indicating the potential for further savings in red cell usage. Then if we carry on, and the note picks up at page 4. In addition, no reduction in demand has yet been achieved in medical patients, nor with the blood products, platelets, nor fresh frozen plasma, because of the lack of audit and studies to generate the evidence base at C Research. For these reasons, there appears to be the need to re-energise BBT. Prof Murphy may ask that the DH communicate their commitment in another document called BBT3, which would include the need for a CMO seminar as before. DN in confidence, there is a feeling that the management of NHSBT do not see this as one of their priorities. Does that reflect your understanding of the position or not?
Yes, it does. And in fact, we did run a Better Blood Transfusion 3 soon after this in 2007.
And in terms of the need to re-energise the BBT and a feeling that the management of NHSBT didn't see this as one of their priorities, again, does that accord with your understanding of the position at the time?
Yes, it does. The involvement of NHSBT in Better Blood Transfusion has waxed and waned somewhat, in my opinion. In the early 2000s, particularly because of the concern about blood shortages, in the case of a test for variant CJD, there was huge interest in trying to promote much better transfusion practice, and particularly use of blood. And so at that time, we were able to get national resources for establishing the National Comparative Audit of Blood Transfusion Programme, to set up a systematic review initiative to collect data, to collect the evidence for transfusion practice, to develop the team of nurses within NHSBT that would provide support to hospitals in regions, and other initiatives. And and we had there was a lot of energy in trying to drive better transfusion practice in hospitals then. I mean, during the last 15 years or so, that perhaps some of that energy has dissipated.
And do you have any sense of why the energy's dissipated?
I think, well, certainly the concern about variant CJD being transmitted by blood transfusion left, and there are multiple other priorities, I guess, for NHSBT, and indeed for the Department of Health, and for hospitals.
These were obviously a preparation note ready for a meeting with the CMO. How often did you meet with the CMO about better blood transfusion? Was this a one-off, or was there a regular set of meetings?
It was not quite a one-off, but it was an unusual event. But the CMOs at the end of the 90s and through the 2000s were very involved in better blood transfusion and were a huge support. And in particular, in disseminating the recommendations from each of the initiatives, the health service circulars, making sure that those were directed at chief executives of trusts, as well as the leaders of national organisations. And I think that was very helpful in keeping up a high profile of transfusion, that this really, really mattered, that it was something, as I say, directed to chief executives. And for various reasons that perhaps I don't understand, that means of communication seems to have stopped now. And I don't know whether that's because the communication from the centre of the NHS to trusts is different. But certainly it was a very effective way at that time in getting these recommendations directly to senior management in trusts.
And at that meeting, it was agreed, as you say, that there would be a further seminar,
Yes.
and in fact then a further health service circular
Yes.
in 2007.
Yes.
For the transcript, it's WITN 7001-011. And in that circular, it's fair, isn't it, that a large number of the recommendations are very similar to what
Yes.
was recommended in 2002.
Yes, and indeed in a more truncated form in 1998. And they were intended to be very direct, to indicate to trusts and to staff in trusts what they needed to do in terms of delivering better care, better transfusion care.
And then in 2014, the approach shifted to one of patient-based management. We looked at a document earlier today, and I'm happy to take you to it if we need to, but can you help us with how that differed, if at all, from the Better Blood Transfusion Initiative?
Yes, so it's patient blood management, and confusing. The focus was more on trying to make sure it was really about use of blood and avoidance of use of blood, if that was possible, and managing patients either with transfusion or without transfusion to improve their outcomes. So there was less of a focus on the nitty-gritty of the transfusion process itself in taking samples for compatibility testing, for laboratory testing, for administering blood, and more about use of blood and avoiding use of blood where that was possible. And we were beginning to get evidence that use of drugs like tranexamic acid could minimize the blood losses at surgery, that cell salvage for patients losing a lot of blood at surgery could also be a very effective way of minimizing the use of blood. So the focus was different. It was moving away from the nuts and bolts of transfusion practice for safe transfusion to use of blood itself.
And along with that came the Choosing Wisely
Yes.
campaign.
Yes.
If we can turn that up, WITN 7001029, please. We see this is an article published by you in Transfusion Medicine in 2015. And we can see the 5 Choosing Wisely questions to ask your doctor in box 1. Do I really need this test or procedure? What are the risks? Are there simpler, safer options? What happens if I don't do anything? How much does it cost? Again, what was the focus or the aim of the Choosing Wisely campaign?
It was to help. It was to help patients being involved in decision making about transfusion. This initiative came from the United States and Canada, and by this time in between 2010 and 2020, I was giving up my national roles in transfusion in England and handing those over to others to take on. And I was beginning to spend more time internationally, and particularly in the United States. And I worked with colleagues in the United States who became aware of the Choosing Wisely program across medicine. This is not just in transfusion, this is across medicine. And we developed some Choosing Wisely recommendations for transfusion in the United States. And when Choosing Wisely as an initiative came later to the UK, and when it came here, I thought that we should make sure that transfusion was thoroughly engaged with it. And we developed some Choosing Wisely recommendations for transfusion, which were obviously rather similar to those that we had developed in the United States. And unfortunately, the Choosing Wisely program has not really generated a lot of interest and energy in the UK, which I think is a pity, because I think it has a lot to be said for it, and particularly involving patients in decision making about their care.
I just want to go to one more document before we take a break.
Yeah.
If we could turn to WITN, just apologies. Yes, WITN 7001061, please. This is the 2021 National Comparative Audit of the NICE quality standards published in February 2022. So I think it came out just last week.
Yeah.
And if we can turn to page 4 of it, we have the summary of the audit.
Yeah.
The audit related to 4 NICE quality standards, quality statements for blood transfusion. And the audit found evidence of significant compliance with elements of them, but with some way to go to achieve uniformly good practice. 59% of the patients who were known to have iron deficiency anemia prior to being admitted for surgery were treated with iron before surgery. 67.5% of patients undergoing surgery with expected moderate blood loss received tranexamic acid. 58% of patients receiving elective red blood cell transfusions had both their haemoglobin checked and a clinical reassessment after a unit of red cells was transfused. 64% of transfused patients had evidence of receiving written or verbal information about the risks, benefits and alternatives to transfusion. Only 26% received both written and verbal information. So that's the sort of up-to-the-minute assessment of where things are at in regard to those.
Yes.
Finally, in your statement, you explained that because of the better blood transfusion and patient blood management initiatives, there's been a 30% reduction in the use of red cell transfusions in England and a stabilisation in the growing demand for platelets. What, to your mind, what were the key reasons for the reduction in red cell transfusions? What in those initiatives made the biggest difference?
I think the evidence that transfusion for patients was not required at the levels that we needed before. So some randomized control trial evidence that we didn't need to transfuse patients as aggressively as we once did. The development of guidelines based on those trials also had a major effect. Maybe concerns about cost of transfusion in hospitals, because hospitals pay the blood service for each unit of blood that they receive. So there were certainly concerns about cost of transfusion at various times over the last 20 years or so. I think those are the main reasons. Also, audit programs demonstrating variation in practice and dissemination of those probably help too.
Thank you. So I'm about to move on to deal with some much more specific issues that we've touched on, and I wonder if now's a good time to take a break.
Yes, it would be. So let's take a break until 10 to 4.
Thank you.
10 to 4.